And now I will request our session chairs to take this session further. Thank you.
Great, thanks very much. So I hope you all had an interesting and networking day yesterday and a nice evening. Managed to enjoy some of the sights and foods of India. I can't tell you how excited I am to be here and to have the meeting here in Delhi. Having been involved from the very beginning with the decision, I can tell you that it has not always been smooth sailing, but wonderful that we're all here. Just so exciting. So we'll have two keynotes today. I will introduce the first one, and Anupam Sachdeva will introduce the second one. The first keynote is the Herb Friedman lecture. Herb was a psychologist, both a clinical psychologist and a research psychologist. And he worked at WHO for about 20 years. And he was really the first person in the organization to shine the light on adolescence, on adolescent health, and certainly one of the champions who moved this agenda globally from the 80s. He was in many ways ahead of his time. Among other things, he stressed constantly the importance of adolescent development, including adolescent sexual development, to the overall health of adolescents. And I was reminded about this yesterday when we had the session on mental health, about how essential giving adequate attention to adolescent development is when we're thinking about adolescent health. He emphasized the need to focus on adolescents on this period of the life course, not only for the health of adolescents, but also for their health when they were adults and for the health of their children. And he was championing this decades, I would say, before the idea of the triple dividend really got internalized. He highlighted the importance of relationships. And again, I was reminded about this when we had the session yesterday on positive youth development. He always stressed the need to integrate our responses to adolescent health. And I have it on good authority, in fact, that it was Herb who coined the phrase adolescent sexual and reproductive health that was used in the Cairo conference in the ICPD. And he pioneered training for counseling. And again, this is a concept that is rippling through this Congress. His passion, his insights, his tireless work ethic has influenced many of the people who have led the field of adolescent health over the last 20 years, and many of them are here today. Bob Blum, Pierre-André Michaud, David Bennett, of course, Chandra Muli, Matti Maddaleno, and of course Jane Ferguson, with whom he worked for many years at WHO. They really were the original A team. I was also fortunate to work with her in the early 90s, and I look back at that time to a friend and mentor, but to someone who I actually often disagreed with. But over the years, on a number of things, on most of the things I would say, I subsequently had to learn the hard way that in fact Herb was right. So he would have been so happy to have seen such a wonderful turnout for this Congress. He was always a great supporter of IAH, and he would have been delighted that a lecture in his memory would be focusing on young people, but more importantly, would be given by a young person. He was a great believer in young people, both in terms of listening to them and having them involved with finding out. He was a pioneer of the narrative research technique, and also in terms of doing. So, Dakshita, please come and take a seat here. Dakshita Wickramatne is Sri Lankan by birth. He's a young researcher, activist, development practitioner, focusing on adolescent health, gender equality, and youth engagement. He has more than as a member of the Every Woman, Every Child Independent Accountability Panel appointed by the UN Secretary General. He previously served as a youth advisor to the UN Women's Global Civil Society Advisory Group, is a Woman Deliver Young Leader, and was appointed as the official Sri Lankan youth delegate to the Commonwealth by the government of Sri Lanka in 2015. Dakshita has a bachelor's degree in social work, a postgraduate diploma in diplomacy and global affairs, and a master's in development studies. He's worked for UNFPA Sri Lanka. He was the youngest assistant director to work for the Office for National Unity and Reconciliation in Sri Lanka, and he currently works as the Regional Advocacy Manager, Asia, for CARE International. Dakshita, the floor is yours.
Thank you so much for the introduction. Makes me feel like I'm not a young person anymore. Good morning, everyone. Namaste and Ayubowan. And that's how we greet people in Sri Lanka. And I'm sure all of you are having a really good time in the 11th World Congress on Adolescent Health in New Delhi. And I deem it a privilege actually to be able to deliver this keynote to you today. First of all, let me take this opportunity to thank the government of India, particularly the Ministry of Health and Family Welfare, for hosting this remarkable meeting. I'm sure the steps taken by your government in promoting adolescent health and well-being have inspired the whole South Asian region, the region where I'm coming from, if not for the whole world. I'd also like to recognize the International Association for Adolescent Health in giving leadership and creating these mutually helpful opportunities, which are actually fruitful learning opportunities for all stakeholders involved in working on adolescent health and well-being, to make sure that these opportunities will uplift the health and lives of young people and adolescents across the globe. As it was previously mentioned, today I'm honored to deliver this keynote in memory of Dr. Herb Friedman, a leading proponent of adolescent health. However, I have to be honest, I haven't had the privilege of associating Dr. Friedman. In fact, I was just 10 years old when he passed away in the year 2000. But I have still been lucky to associate people who are inspired by the work and commitment of Dr. Friedman, and I was able to read many briefs and commentaries about him. In fact, one editorial written by Dr. Robert Blum and my dear friend Dr. Jane Ferguson has moved my heart and soul. I cannot do any fairness to the work of late Dr. Herb Friedman, but I'll at least try to do some justice by reading these few lines before I start my keynote. In the past 2 decades, there are many reasons and forces for the increased attention given to adolescents, but such forces in themselves would not have put adolescent health and development on the international agenda. Rather, it was these forces coupled with the dedication and skill of a small number of world leaders who made it happen. One such individual was Herbert Lloyd Friedman. The footprints of Dr. Herb's work are seen in the towns, villages, and capital cities of the world's nations. The world is a better, or at least a healthier place for young people today than a decade ago, not only because of globally negotiated documents in and of themselves, but because of those like Dr. Herb Friedman, who have provided us with such inspiration to guide our work. We are still striving to actualize this vision of harnessing the force of adolescents for themselves and for their society. With that note, let me start sharing my thoughts on young people changing the future of adolescent health across the globe. I believe that young people and adolescents are the future of society, but they are also very much its present. They are not just leaders of tomorrow, but they are leaders of today. As evidence from statistics and experience show, adolescents who are healthy and are happy are better equipped to contribute to their communities as young citizens, despite the major shifts occurring in the world they are about to inherit. Adolescence is a dynamic concept that is being defined even now within the context of a life course approach to health and development. There are a diverse group of people, all experiencing numerous life changes, physical, mental, and social, that will affect their health and well-being for the rest of their lives. Given these differences, it's imperative to note that the markers of international recognition of the importance of adolescent and youth health exists nonetheless. For example, commitments made by the World Health Assembly in Geneva in 1989 were reinforced by the specific recommendations of the International Conference on Population and Development, frequently referred as the Cairo 1994, which in turn contributed to the gender-specific achievements of the United Nations Fourth World Conference on Women, Beijing 1995. As a consequence, the international community has become increasingly inclined to identify adolescents as a distinct group for public health attention and as one in need of ad hoc, gender-sensitive reproductive health programs, education, counseling, and services provided within a framework of respect for their rights and responsibilities as individuals, partners, spouses, and parents, as well as members of families and communities and nations. Sadly, at present, the bitter truth is that almost 3,000 adolescents die every day. Top 5 causes being road traffic accidents, pneumonia, suicide, diarrheal diseases, and drowning. Nearly all these deaths are being preventable. Moreover, studies of health inequality show that the adolescent population is very much affected by the social divisions in society. Young people living in poverty and deprivation have poor health and have particular needs in terms of service delivery. Unfortunately, these young people and adolescents who need healthcare the most are the ones who have the least access to it. There is also a discourse about risk-taking. Still, we talk about adolescent health. We have this discourse about risk-taking. Many professionals have often taken a gloomy view, sadly, of adolescent health. Substance misuse, binge drinking, suicidal behaviors, road traffic accidents, sexually transmitted infections, and other so-called risky behaviors, to illustrate that the current generation of youth and adolescents has no regard for health and healthy living. It is of paramount importance to understand this universal truth that taking risks is mostly a part of a learning process for adolescents and young people. Without experiencing health behaviors that involve risk, I think adolescent young people can develop notions of what is safe and healthy for them. If all behaviors that have potential risk for health were to be avoided, then adolescents would not be able to learn how to manage challenges and overcome these obstacles. Amid all these challenges, young people across the globe are changing the future of adolescent health. And I'd like to capture these changes under 3 pillars: actions, commitments, and transformation. Or as hashtag ACT in urban millennium slang. So let's get into actions. Speaking from the Sri Lankan experience, I first started working on adolescent health and youth health as a volunteer of Family Planning Association Sri Lanka in 2011. Little did I know how challenging and politically sensitive this field is. The important aspects of adolescent health and well-being are mainly considered to be the taboo in many societies in the global south, including Sri Lanka. There was and still is the question of negative stereotyping or the demonization of youth. As I have seen, this has a profound influence on how adolescent health is understood by the adult world. It also has a critical influence on how services are organized and delivered. At a time where governments are struggling to break these stereotypes, young people back in Sri Lanka were quite successful in using some innovative approaches to build a national dialogue on adolescent sexual and reproductive health through a national level debate competition, which reached out to more than 800 young people and engaged almost 30 national and local policy makers, including the parliamentarians, in 2011. Moreover, Road to Adulthood, which is also known as Cyberpeer, which is an initiative of YPA International with the support of the United Nations Population Fund, we in Sri Lanka found the first ever computer-based learning tool on sexual and reproductive health, developed in partnership with the University of Sri Travadapura, one of the main universities in Sri Lanka. And this tool is being piloted by 15 universities right now in Sri Lanka with the approval of the Ministry of Higher Education and the University Grants Commission. Another innovative action young people have taken in Sri Lanka is with people living with hearing disabilities. Official statistics estimate the population of people living with hearing disabilities in Sri Lanka to be more than 300,000. Furthermore, the National Policy on Disabilities has accepted that sign language more often than not is the only language of communication for people with hearing disabilities. But sadly, given that sexual and reproductive health and rights is a taboo topic in Sri Lanka, imagine the challenges people with hearing disabilities would face communicating to each other, expressing themselves, and trying to recognize their rights. So what these young people did was actually, when they understood there's an issue, they worked with the Center for Disability, the Ministry of Social Services, and trained sign language interpreters in terms of developing their skills, because they worked as a mediator between people with hearing disabilities and the service providers. And in fact, later on they developed a toolkit called We Hear You, which has specific signs for sexual and reproductive health and rights terms. And with this sign language glossary, now the government will introduce a sign language bill to recognize sign language as an official language in Sri Lanka. The minister had pointed out that official recognition of the sign language will allow a person with hearing disability to access education and have government services delivered to them without any discrimination and challenges. So these are youth-led activities taken by the young people in Sri Lanka. But I should also recognize the fact that young people in Sri Lanka are not the only ones who have been turning the tides. There are young people across the globe who's doing that. In fact, I can name a few people, but there's a lot. Tansila Khan from Pakistan, a young woman living with disability who's an inspirational speaker, and she's a public figure now. More than 300,000 young girls and adolescents are following her. There's Oko Arma Francis from Ghana, who should be sitting somewhere. I'm sorry, Oko, I can't find you right now. And there's Shanshan Lee from China. And they are young people in Ghana and in China who are working as PA educators, as youth advocates, pushing the governments to have more progressive policies in their countries. And the list could go on. And these are just three of many who are turning the tides across the globe amid social, economic, and even physical barriers. So let's get into commitments. The voices of young people are already influencing the policies, as I mentioned before. This may be where young people are asked about service delivery, or where they are given an opportunity to say what they want from treatment, rather than have an adult be thrust upon them, especially with regard to policies on adolescent health. All the evidence shows that the more young people can be given a voice in health matters, the more they will engage with health and the more likely they are to pursue a healthy lifestyle. Many youth-led and youth-serving organizations have challenged adult-led organizations in the health field to ask themselves to what extent they were listening to young people in their work. For me personally, the Family Planning Association Sri Lanka and International Planned Parenthood Federation was one of the best examples. If not for these organizations, I wouldn't be here today. In fact, IPPF has a global standard, I'd say, to have at least 50% of people at the governance levels to be young people and more than 60% of them to be young girls. And this is being practiced in most of the national family planning associations. As I said, regionally, because the Asia Pacific region is closer to me, I should definitely mention some of the organizations who are engaged in making sure that the government will honor the commitments they have made. So, for example, the UNFPA's initiative of 5-year, especially in the Asia Pacific region, and also in the Middle East and North African region and the Eastern European region, are doing a massive job in terms of reaching out to adolescents and young people in schools and also out school, providing peer education, services and information. Asia's Safe Abortion Partnership's Youth Champions initiatives will be recognized with supporting young people, especially young women and girls, to lobby for this, have more progressive laws on safe abortion across Asia and the Pacific. Youth Lead and Youth Voices Count are key youth-led organizations working in Asia for the rights of the young people population of HIV, including young people living with HIV, young drug users, young sex workers, and young men who have sex with men. Many more organizations globally, including Women Deliver, PMNCH, Plan International, are doing this job. And to look at national level commitments, I should again recognize the Rashtriya Kishore Swasthya Karakam program, frequently known as RKSP of India, to be a great example of government taking leadership and honoring their commitments. The program envisions enabling all adolescents in India to realize their full potential by making informed decisions. But this is actually the good side of commitments. But I think I should get into some of the challenges faced by young people across the whole world in terms of holding the governments to account. For example, the conversation on comprehensive sexuality education has been there since, I guess, 1994. But still, most countries are still struggling to have comprehensive sexuality education in their schools. I just have one statement to say about that. I think comprehensive sexuality education or life, I think WHO uses a different term, I'm not familiar with that, life education. Whatever it is, CSC has to be in schools, period. There's no discussion about that, because sexual education is not just about teaching young people about their sexual organs or reproductive system, but it's also about respecting each other, understanding this diversity and giving them this sense of empowerment to make decisions over their bodies and their lives. Also, pivotal laws across Asia still prevails, which actually restricts young women and girls from seeking safe abortion, but also which restricts people with different sexual orientations and gender identity and people living with disabilities. In fact, there's a threat to many young people across the globe who work as advocates and activists, especially with certain restrictions of particular governments with regard to their safety and security. In fact, many young people I know have been put into prison or their work as result of the organizations are being closely monitored. And also it's important to note that some governments in Asia sadly have really restrictive laws and policies that in fact, for example, people using drugs have been killed. Especially recently, there's a Southeast Asian country where a young adolescent of 17 years old was shot dead. Still, under all these difficult and challenging environments, young people are fighting for equality and trying to hold their governments to account. And my final point on commitments is actually on outcome statements of these meetings. I believe that there has been a lot of outcome statements, many agreements, and I particularly think take these meetings as yes chambers because all of us agree to deliver, and I think the conversation needs to go beyond this particular room. And for us to do that, the best way is to use these outcome statements, but to make sure that we will honor these commitments and not just make it just another document, but to use it as something which we can use to influence policies. And I'm sure young people here today in this particular meeting will be also presenting an outcome statement, and I'm sure they'll be doing their best to deliver it, and I expect all the other stakeholders honor their commitments to these statements as well. And can I get a yes to that? This is the slide I was thinking of using for advocacy, but I missed it. Also, the final point is about transformation. The discussion on youth voice has clear links to notions of participation and empowerment. The more young people believe that their voice is being heard, the more empowered they will feel. However, I believe that young people can participate without feeling empowered. And indeed, they can and must be allowed to speak without anyone taking any notice of what they say. For this reason, it is as much the quality and intention of the involvement of young people that makes the difference, rather than the formal arrangements established by the adults involved. There are many types of participation, ranging from the tokenistic to the fully engaged and involved, as has been well rehearsed in the discussions about Hart's level of participation. It goes without saying that the greater degree of genuine participation, the better it will be for the health of young people. I will instead not do justice to my feelings if I do not share my observations on the current trends of youth participation globally as someone who has been an activist and a youth advocate for more than 8 years. We must recognize the diversity of professional and career goals and needs of all youth advocates. I feel that there are general assumptions made on youth participation which may not be the case. We have to understand that every youth advocate might not want to become or have desires to become global and voice on youth or winners of these flashy awards and titles. I have seen and I know that some would remain at the grassroots level in their villages, focusing only on uplifting their families and communities. That is the transformation they like to see, not to pursue some of these flamboyant titles. I think this trend has created some unhealthy competition between young people engaged in development, and it can actually do more harm to the field of youth advocacy than benefiting. So in conclusion, it is essential that policymakers and practitioners seek to address the negative stereotypes whenever possible.
For the opportunity to join you at the 11th World Congress, and congratulate to the Government of India for their hosting of this, in particular the Ministry of health and family welfare. And overall, congratulate the organising committee and yourself for being so wise as to take advantage of this unique opportunity. When we consider that the population of adolescents globally is at its highest level ever, if we factor in where it is those young people are most concentrated, if we examine how current policy and practice are treating them, and if we look out onto the world that we are bequeathing to them, then the urgency of acting more decisively, more conclusively right now becomes clear. Acting now to ensure this enormous reserve of potential is not denied its contribution, but is enabled to emerge into the flow of our world's challenges as influential, powerful actors of positive change. And our mission, the SDGs tell us, I believe there is something missing. Why, what, how? What's missing is a question of who. Just by sheer scale, in this century, age will join gender and ethnicity as the pivotal identities. How we interact this century with age will determine in which direction moves the future of planet peace, prosperity of people. But buried under this new reality is a new inequality. Age-based inequality, not merely age-old discrimination. And it's this inequality that is at the heart of today's patterns of migration. After all, 90% of the world's adolescents are living in low-income countries from where a majority of the world's irregular migration come. 90% of those who are aged and aging further are living in high-income countries. Countries of destination, the source of some of the most malicious migration policies we see today. The median age of Niger and Uganda, 15. Of South Sudan, of Central African Republic, of Somalia, of Yemen, the places of conflict, 17. 18, 19. The median age of privilege, Japan, 47. Germany, 45. And the median age of parliamentarians, 53. Friends, youth is poor. It's subjected to the greatest of insecurity. It's on the front lines of conflict. It's populating the roads of escape. It's locked in the back rooms of neglect. It's kept outside the rooms in which decisions made affecting them are taken. If we want, and goodness me, no, we need to effect positive change, we have to dismantle this exclusion. As Einstein said, you cannot solve your problems with the same thinking you used to create them. We cannot solve these problems with the same thinkers. We have to bring in new thinkers, different ones, younger ones. You know, adolescents are always on the move. They're on a journey from childhood to adulthood. No wonder, when needed, they seek refuge in safer neighbourhoods. This is more a question of rights than it is a question of migration alone. Rights, they're just a binary definition of what it means to be human. Medical science codifies anatomy, physiology, or musculature. Human rights, they give us internationally defined definitions of how we are all precious, unique and equal. Human rights doesn't prevent our diversity, they protect it. Doesn't limit our diverse expression, they ensure it. Doesn't restrict our access to cultural belief or opinion, they guarantee it. And however desperate, being on the move does not and cannot erase your rights. People on the move, like people who have no movement, have human rights, inalienable, universal. And the opposite of human rights upheld, selfishness, bullying, bigotry, injustice, tyranny, oppression, toxic stepping stones, a perverse paving of pathways to privation, to suffering, and ultimately atrocity. contempt for the other, hatred of the foreigner, distrust of those who look or love or worship differently, aided and abetted today by clampdowns on freedom of the press, stepped up surveillance in cyberspace, encroachment on public movement, closure of national borders for people fleeing persecution, gagging of activists, the deprivation even of life-saving services such as those essential for sexual and reproductive health. The pounding of these malicious fists grow louder and louder on the doors of our dignity, our privacy, our mental and physical integrity, and against our freedom, and this must be resisted. We know only too well where this toxic path leads. Humanity has travelled down that path before. It leads to a dead end, to death-ridden ends. And in this struggle against exclusion and against bigotry, I'm sorry, there's no north or south, there's no right or left, there's neither east nor west. There is only the humane and the inhumane. And in this world, it's a fallacy that borders, walls and fences erode our obligations to each other's rights. Walls within the human family, on a small, distressed planet in a globalised world, home to the largest population of the youngest people in all of human history, walls are untruths. There is no country on this planet at this time in this interconnected world that can rightfully stand apart, bury its head, or absent itself from the global table of rights-filled solutions. You know, in Nicaragua, once I sat down with a 14-year-old girl to listen to her story. She had a baby on her lap and a child was free at her knee. The baby's father, her boyfriend, was no longer living with her. He had become violent, and she had taken her children on a long and perilous journey away from home, family and friends, seeking safety. Staying temporarily in a youth shelter, she explained that her older boy, clearly hyperactive, was the product of rape at the hands of her uncle. She, at the age of 10, had sought a termination of that pregnancy, but the state denied it to her. Throughout our conversation, she cried. She was explaining too that once she had dared to hope to stay in school when she had dreamt of being a nurse. It was just so painful to both listen to her story and for her to tell it. I asked her why was she taking that care. She explained that she was speaking to me because she believed that people like us can make a difference, so that other girls need not go through what she went through. You may not believe in you, and at times you likely won't, but she believed in you. And young people, this is where you come in, and we oldies must let you in, to take the dynamics of this interdependent, interconnected world of change and twist and turn them so that opportunities are maximised and threats minimised, so that preventable suffering is eliminated, so that hate is never the basis of public or private action, so that the ecology of our planet is rescued from our greed, so that innovation in technology, science, philosophy, art, literature, music can involve us into greater compassion, greater humility, and a less self-first approach to daily global action. And for this we must invest in young people, pave their way, dismantle the barriers that block their way, and then get out of their way. For we may not have left a better world behind for our children, but we can and we must leave better youth, better men and women for the world they have. Thank you very much.
Ladies and gentlemen, I think that was a brilliant talk, a very passionate talk, and shows our commitment towards purpose. Thank you very much, Kate, for enlightening us and for bringing us to speed. I think we'll close down this session with this talk, and I request the organizers to please take over the stage. Thank you. I think she deserves a standing ovation.
Well, thank you so much, ladies and gentlemen, for an inspiring and passionate session downwards. Yes, it makes us think that, we don't have to make this world a better place for some, but yes, for everyone. And one thing that we can do is act, commit, and transform. So, ladies and gentlemen,
focusing on young people exposed to armed conflict, forced migration, and poverty. Her objectives for the Young Life Study is to focus on research for policy and program design aimed at enhancing young people's well-being and development. After that, we will have an opportunity to hear from Professor Robert Blum, who has attended every International Association for Adults and Health conference since 1979. And that was in Washington, D.C., when his now 40-year-old son slept on the floor next to him when he was 2 years old while he spoke. Professor Blum's international work began in 1987 when he was on sabbatical at WHO at the recommendation of David Bennett, who had spent some time there 2 years ago. The first paper he ever wrote on adults and health globally was at the urging of Dale Garrow, one of the first generation leaders of the Society for Adults in Health and Medicine. After that, Dr. Rajit is going to give us a view of India and adolescent health. Dr. Rajit works for the Population Council, and his areas of work include youth and adolescents, early marriage, maternal health in general, and abortion in particular. He loves photography, is a mountain trekker, and he has an adolescent son, so he's very close connection with adolescent health issues. Because of his long-standing interest in an early adolescent, he is here to share his experiences with us today. Thank you, Dr. Joy Gordon.
Good morning, everybody. I want to talk about what I feel are the most important ways of understanding and seeing adolescent lives and how these might impact their health. We all know what the major challenges are in adolescent health. They're lagging behind all others in progress. Adolescence is when so many of the major health problems of adulthood arise, yet they're very low in policy priorities, and also they're the least likely to access health services. My central argument is that we need a far better understanding of their daily lives in order to explain what is going on in terms of these challenges. So I'm going to draw on some evidence from Young Lives, the study that I direct. We've been following 12,000 children in Ethiopia, in India, Peru and Vietnam since 2002. We've conducted 5 survey rounds and 4 waves of qualitative.
50% said sanitary napkins. So we asked those who did not use sanitary napkins why did not they use. The 3 major issues are here. They can't afford it, difficult to get, or feel shy to buy it from somewhere, who do not know about sanitary napkins. Second, self-reported SRH problem. A significant minority of them reported so, particularly boys, 60% of them reported self-reported SRH problems. More boys and girls reported a problem. Treatment seeking, those who had a problem, we asked them whether they sought treatment or not. and about 66% boys versus 21% girls said they sought treatment. And the place they wanted, the preferred place they wanted to go, or actually gone, is private facility or doctor. Coming to nutrition, we asked questions about their dietary practices. We also tested for anemia and also measured their height and weight. Looking at the daily dietary habits, you see most of them don't get proper diet. On an average, not more than 2 food groups are consumed by adolescents daily. Less than 1% had all food groups consumed every day. 5 to 8% had none of the food groups covered in their daily diet. The nutritional status, anemia, 55% of girls and 34% of boys had any anemia, 13 and 6% had severe anemia. Looking at stunting, 29% of boys and 19% of girls had thinness, severe thinness. If you look at the numbers, what it translates to numbers, we have a huge burden of anemia in this study stage. About 6.6 million boys and 20 million girls are anemic in these two states alone. 1.2 and 2.8 million were severely anemic. Going to mental health, it's a new area. We asked questions on testing time tested that age to 9. 9 questions were asked related to sleeping, eating, patterns, concentration, feeling of tension, depression during the last 2 weeks before the survey. Special training was provided to investigators to tackle this question, to ask this question properly by the experts in the field. The score ranges from 0 to 27. Also, the last 12 months, whether they had a special pregnancy, attended to public suicide, we asked of those aged 13 and 14. Also asked questions on self-harm on 3 dimensions. Mental health condition, if you look at this, 38 and 45% boys and girls had mild depression related, sorry, not 38, 3.24.5% had mild depression related symptoms, and about 9.9% girls also had moderate to severe depression. Look at suicidal tendency or self-harm, about 5 to 6% reported they ever attempted to harm themselves. Again, considering the numbers, 2.4 million in the last 1 year in these 2 states alone repeated self-harm. 1.9 million showed some symptoms of depression. 0.4 million considered suicide. Looking at the injuries and violence, we also asked about whether they had a road injury or injury in any other ways, and about 34 and 20% reported there is injury in the last 12 months. So 1/3 of boys and 1/5 of girls. They also face violence at home, violence outside home. Violence at home, half of the boys, and slightly less than that, 27% of the girls reported were beaten by their parents in the last 12 months. Violence outside home. Similar proportion, they fought with somebody, about 46 and 30% of boys and girls reported so. Fifth is the substance use. You know, about 4% of boys and 1% of girls reported that they used tobacco products in the last 1 year. Alcohol, never consumed this, and in the last 1 year, 1 week in the last 1 month, about 2% of boys reported so. Whether they have program access, we talk about program where we have programs covered. 33% girls knew about the sanitary napkin program. I talked about sanitary in the beginning. Only about 10% received benefits of it. Only 1% know about our flagship program, Heart KSK. About a quarter of boys and girls received health services information at school. Almost everybody knew there was an Anganwadi worker in the village area. 56 to 56% knew about the ASHA worker, but only 4 to 7% of them received any services or information from them. So in summary, although one perceives that early adolescence is a period of good health, there are serious health issues in this group. The burden of anemia and chronic malnutrition is huge, ticking bomb of mental health problems, a real threat we need to tackle urgently. The number of adolescents affected by injuries is quite helpful. Program access is limited. The flagship RKSA program is struggling to reach adolescents. However, we also have hope. We have commitment to this group where we can overcome all these problems. So, thank you.
Good morning. I hope that you will be able to hear past the voice quality to what I have to say. But at least I'm pleased that I'm able to speak at all. The work that I'm going to share with you on empowerment is embedded in a much larger multi-country study, the Global Early Adolescence Study, which has taken place in 15 countries on 5 continents. We were interested, among many other things, in understanding empowerment in early adolescents, 10 to 14-year-olds. The reason why we were so interested is because there's so much work being done. There's so many investments programmatically in empowerment. So our starting point was there must be a construct, there must be a concept of empowerment. Last evening I actually went online and Googled youth empowerment. An endless number of things came up. Youth empowerment in India, in Zimbabwe, in Nigeria, in Kenya, South Africa, in the Philippines, and on and on and on. So there's so many programs. Somebody must know what youth empowerment is. Well, when we went out to look at the literature as the prelude to the work that we did, we saw many different concepts, constructs, and definitions. Youth empowerment, enhancement of assets and capabilities of diverse individuals and groups to engage in influence and hold accountable the institutions that affect them. That is definition. The expansion of people's ability to make strategic life choices in a context where this ability was previously denied, something internal to them. Another definition, and the definition that we use for our work, is the World Bank definition, the process of enhancing an individual or group's capacity to make effective choices. That is, to make choices and then to transform those choices into actions and outcomes. I'm going to come back to that at the end. But what that definition says is there are really 2 components. There's a process component to empowerment, and there is an outcome component. Agency is a key element as the thinking has been articulated. The ability to act on behalf of what you value.
Public policy advisor for sexual and reproductive health and rights across the globe. Throughout her career, she's been a passionate voice for social justice, social change, and adolescent and youth health. Ma'am?
Thank you. Wow. Such a pleasure to be here. And really a special thank you to our researchers for giving us a view into the lives of 10 to 14-year-olds. And Bob, especially for elevating issues of agency and of empowerment, and of most of all, giving young people that opportunity for empowerment. Critical to think about. It's been clear to all of us in this room that adolescents matter. And now I think it's even more clear that early adolescents matter. At the Packard Foundation, we focus on sexual reproductive health and rights. We think about services, we think about policies, and most of all, we think about social norms. And as I was listening to our researchers, I was thinking, what we really need to be about is understanding social norms and thinking about how we can shift social norms. At the Packard Foundation, we've long cared about youth. But more recently, we've had the feeling that young adolescents, that 10 to 14 age group, that age group that rarely shows up in our data, really are critical. And yet we have paid too little attention there. So we ourselves have done some refocusing. We think that we have to start early and we have to stay long. And that's an important message for our policymakers, our communities, our parents, and our caregivers. When we think about young people at Packard, we think a lot about them as recipients of education and of services. And we like to think about what really makes a difference. How do they really understand what we have to teach them? And what matters to them when they go in to seek health care? We also think a lot about young people as movement builders, as activists. And we have come to think that even our youngest teens, our 10 to 14-year-olds, can also be leaders, that they themselves can guide and build on their strengths. And I think in Bob's research, he talks about letting the young people form the questions, and that's really important. When we think about young people, both as recipients and as movement builders, we like to look at the evidence. We like to look at research and think about what really works. And we like to listen to young people themselves. It's clear to me, listening to all the evidence we have heard today, that we have to pay keen attention to gender. That really matters when we look at programming for young people. Where we work with young people around the globe, from Mississippi to Amhara to Bihar, tends to be amidst poverty, violence, weak systems, and patriarchy. And with our global leaders right now, we are living particularly in an era of misogyny and patriarchy. And what we see is there are very few safety nets for young people and for people in general. This makes this life stage, this adolescent life stage, a period of marked vulnerability and a period where there is particular risk around sexuality for young people. And yet what we wish for those young people is to actually have a positive sexual experience.
It's been an incredible conference, and of course, I see a lot of young people in the room, and I just want to remind you that the main reason why you come to these conferences is so that you meet other people who have the same interests from all over the world, and then you come back to IAH in 4 years, or 3 years, or maybe even 2 years if we're lucky, and you get to see them again, and your networks broaden and broaden and broaden, and you always, wherever you go in the world, you have somebody to have dinner with. So, welcome very much to the session on interactive media. My name is Miriam Kaufman. I am the recently retired head of the Division of Adolescent Medicine at the Hospital for Sick Children in Toronto and a professor at the University of Toronto. And I'm very happy to be co-sharing the session today with this guy.
Hi everyone, I am Pierre Michaud. I am a retired professor in adolescent medicine, Lausanne University. For those who have already heard me, I am also the co-chair of the scientific committee of this Congress, and it's a pleasure to be here today with you. I am Swiss, so we will be very sharp respecting the timing. We have the choice.
And I'm Canadian, so we'll be polite about it.
We have the choice between a Swiss clock or an iPhone, but both work perfectly well. I must say also that I'm replacing Poonam Mutraja, who was supposed to co-facilitate that couldn't come. So our first speaker, please is Mr. Emmanuel Adebayo. And the title of his presentation, as you can see, is Social Capital Among Adolescents, Comparison of Online and Offline Relationships as Sources of Social Capital Among In-School Adolescents in Oyo State, Nigeria. Thank you very much.
Good morning, everyone. My name is Emmanuel, and I'll be presenting on social capital among adolescents, a comparison of online and offline interactions as a source of social capital. As a form of introduction, we all know that adolescents are neither children nor adults. It's a period where they're trying to figure out who they are, and in figuring out who they are, they need support. And it's also been said that the adolescents seem to mirror their environment. They see themselves through their environment, through the people within their environment, parents, family, friends, schools, or community. And social capital itself is not just the presence of these social support systems, the presence of a family, the presence of a friend, interaction with neighborhood, but it's the benefit that you derive from these mutual interactions. So we measured social capital as two types, bonding and bridging. Bonding is a deep relationship with people. Bridging is wide but shallow kind of relationship. And we measured two sources of interactions adolescents have. So the face-to-face interaction, like the type we're having now, and online interactions, majorly focusing on social media interactions. So, social techno capital, as it has been called, is a form of social capital that has been said to be able to, that you can derive from internet interaction. Initially, in the early days, it was said that internet interaction sort of reduces social capital amongst individuals because people spend more time on the internet than they spend interacting with people. But these days, it's also been said that you actually interact with people online, and therefore you sort of maintain social capital through online interaction. So in this study, we focused on adolescents because the group of adolescents we have right now, adolescents who sort of grow and develop online, they spend a lot of time online, and this study tried to explore the availability of social capital online and then compare it with offline social capital. 1,200 adolescents were recruited for the quantitative aspect, and 64 in-depth interview was conducted among adolescents for the qualitative. Social capital was measured through measuring emotional support, access to scarce resources such as money, connection to people with similar beliefs, outward looking, contact with a broad range of people, and then a view of oneself as a part of a bigger community. As of results, adolescents maintain, it was found that adolescents majorly maintain old relationships or offline relationships through online interactions, and that there are friends and there are friends. So adolescents have just an average of between 2 and 3 friends that they derive social capital from offline and online. And so 54% of them also said that they had the same friends offline as online. So they mostly follow up their offline relationships online. If we look at the table there, it's find that social capital online was significantly higher than social capital online. And if you look at the age disaggregation, you find that earlier social capital seemed to increase at mid-adolescence, but then decreases at late adolescence. And then social capital online seemed to increase with increase in age because they get more access to internet services. Within the family, social capital was significantly higher online than offline. Offline than online. Adolescents said they hardly interact with parents, siblings online, except when they were not within town or were schooling somewhere else. Significantly, family social capital was also significantly higher than peer social capital offline. But then online, peer social capital was higher than family social capital. It means that adolescents gained more social capital from their friends online than they gained from their family online. And then Their social capital was also higher offline, significantly higher offline than online, because 50% of them said they had interactions with the same set of people offline as online, but they get more benefits from relating with their friends face-to-face than from relating with them through social media. And then in comparing the bonding, that is the depth of the relationship, both offline and online, adolescents had significantly higher deep relationships offline than they did online. But they had a significantly higher broad relationship online. In the qualitative, adolescents actually consider the types of people that they relate with and they call friends through their behavior, trust, and then sharing of scarce resources. So adolescents said that their friends were mirrors or extensions of who they were. And so they were being careful of people who were not who they want to be. And so they picked friends based on, or they interacted with people based on who they were. Adolescents hardly made new friends online. And when they do, some of these friends, online friends, were extensions of offline introductions. So an offline friend introduces an online friend, and then sometimes when they join new groups, the new groups were also created by offline friends. So as a form of implication of this study, online relationships are extensions of offline relationships. But then online relationships are as important as offline relationships because bridging social capital is higher online. And it's been said that in the world we have now, it is not just enough to have a cocooned relationship. It's not just enough to have deep relationship with few number of people. It's also good to have a broad relationship because you have a balanced perspective of the world you live in. And so bridging social capital is very important amongst adolescents, which make online interactions also important. So the benefits of online interactions increase with better monitoring. Adolescents who had monitoring of their internet access had higher social capital than those who just had free-range access to internet access. Interactions are important for social capital. Social capital is important for good health. An extension of this study, we found that adolescents who had high social capital had better health indices as compared to those who had low social capital. And those who had monitored internet access also had better social capital because they spent less time online and spent more time offline interacting with people. It is important to keep strengthening adolescents' offline interaction, because, especially within the family, because the family seems to play a very large and huge role in social capital development amongst adolescents. There's nothing we can do about social media. I mean, there's a lot of talk about the negative impact of internet relationship amongst adolescents, especially in developing countries like Nigeria. But there are positive outcomes of internet relationships, internet interactions, and that's what this study has proven, that there are forms of social capital, positive interactions online. So what we need to do is build the skills of adolescents to build positive contact with their own interactions. So if I have good interactions online, if I have good relationships online, then I also can have good health outcomes. I can also have good health indices. And that's what the take-home message from this study is. Thank you very much.
Thank you very much. It was well presented, well done, brilliant. Thank you so much. Just a very short comment from me. We did the same kind of survey in Switzerland, okay? Totally different context. Many adults tend to think that people who spend a lot of time on the internet or iPhones do not socialize correctly in the real life. And actually we have exactly the same result as you have. Both people who socialize much on the internet also have many friends in reality. And I think it's an important message for health professionals and parents. So thanks a lot.
Thank you very much.
Question from the floor or comments? Yes, we have a mic here.
Thank you for the presentation. I just want you to throw more light on monitoring you talked about benefits online increase with better monitoring. So I was wondering, who does the monitoring? Is it the parents? Is it the peers? Who? And if the monitoring is done, how does it increase the benefits? Thank you.
Do I answer that? Okay, so in this study, the monitoring was focused on parents. So parents did the monitoring in this study. But there's a study that also talked about the school. So school had internet access, but then they blocked off some sites that adolescents could not visit. And they found that it also increased social interaction amongst the adolescents because those sites were not available for them to visit. I can't remember what the sites were right now. But in this study, the focus was on parents being the monitors of not necessarily the interactions, but then the access to the internet itself. So they had limited time to spend. Those who spent less time online spent less time offline. And because offline was an important form of or source of social capital, because most of their relationships online were an extension of offline interactions. It means that if they spend less time online, they get to spend more time offline. And then spending more time offline increased their social capital. In fact, spending time offline gave them more things to discuss online. Their offline interactions, offline relationships, offline socialization influence the things they do online.
Yeah. Thank you. We have time for one or two more questions over there.
I was wondering if you could tell me a little bit more about how does this result play among men and women, like boys and girls?
Okay. So an interesting thing is that social capital was significantly higher among females as compared to males, especially offline. So in an initial study, not this one, an initial study on social capital, we found that female adolescents had higher social capital. But in that study, what we did was we measured what they did at home and what they get from home. We found that females had higher because they did more at home and also had I don't know what word to use for it now. Because these studies are actually their perception of what they get. They had a better perception of what they get from their parents than the males. The males seemed a bit flimsy about what they derive from their relationships. But generally, at school too, females had better social capital. Some studies have said that females are seen as easygoing, calm, while the males are seen as troublesome, and so they have less interactions with their teachers, because school social capital was measured based on interactions with teachers. Online also, females seem to be more expressive in talking with adults than males were. Males were more focused on interactions with their peers, and even interactions within their peers, we found that the interactions they had with their friends were not deep interactions. They had sort of shallow interactions. Their deep-seated fears were not always discussed amongst themselves. But females sort of were more expressive about themselves with other adults. And so generally, they seem to have better social capital across the domains that were measured than the males.
Okay, we have time for a last question or a comment. Yes, please.
Hi. Sorry. Hi. Thank you for the presentation. That was very interesting. I was just wondering, and I'm not sure if this was within the scope of the study, but if you have any recommendations on how some of the more stronger offline interactions can be translated to online spaces, especially for young people. So even though if they're spending less amount of time in online spaces, they are more productive and constructive conversations and discussions. Thank you.
Okay.
Short answer.
Okay, thank you. So this was not within the scope of the study, as you said, but then one thing we have done that has not been documented, or that have tried that have not been documented, is asking adolescents to create their own contents from interactions. So I have a group of young boys that we meet regularly, once a month or twice a month, as opportunity gives. And what we do is, from the discussions we have, they create snapshots of Twitter messages that they produce themselves, and then they go online and tweet these things, or Instagram, take pictures, and then they create some of these things. There are also studies on use of photo voice, where they take pictures and then they post these pictures. And I read something amongst the posters yesterday, the abstract yesterday, that talked about adolescents also creating their own social media content. So I feel that's one of the ways you can increase the productivity of online interactions, as even though reducing the time they spend online too.
That was a terrific start. Thank you. Our next paper is promoting the uptake of HIV testing services among adolescents through rollout of a two-way interactive short messaging service channel, and that's going to be presented by Tinashe Rufus-Wadso.
It's a beautiful morning to you, ladies and gentlemen. My name is Tinashe Rufus-Wadso from Africa Exchange Program in Zimbabwe. I'm going to be talking about the issues around HIV testing services amongst adolescents and young people, and how, as an organization, we have managed to make sure that we are also contributing a lot to the 1999 targets. So in Zimbabwe, we've got a large proportion of adolescents and young people. And within this age group, we've got about 60% of them being between the ages of 10 up to 24. And we have got 77,000 children who are HIV positive and 69,000 adolescents who are also living with HIV. And from my own perspective as a young person, this is an issue which has to be taken into account in terms of disseminating information on HIV, on HIV testing services. So we asked ourselves on what exactly needs to be done, because we were looking at these young people not having access to information, some of them in the rural areas not having access to some of the social media platforms where we can also communicate about. Then we said there's also need of innovative strategies which can lure adolescents and young people to access youth-friendly services as well as information from health services. So we are also looking at improving adolescents' knowledge levels on HIV testing services, including those in rural areas as well as those with hearing impairments. So what we then did in collaboration with UNICEF Zimbabwe was to work on a U-report system which is being implemented in Zimbabwe, and this is a free SMS tool for our community participation. Adolescents and young people, they receive messages, they can also take part in polls, in surveys, and to mention but just a few. So as Africade, a community organization in Zimbabwe, through its Shandiri program, literally meaning accept me as I am, we said to ourselves we need to make use of this opportunity to disseminate information around sexual reproductive health, HIV information, to offer counseling to the young people as well as referrals. So we say to ourselves we just need to see how best can this work as a pilot, and we trained about 10 cats. The cats which I'm referring to, ladies and gentlemen, is not an animal, but these are community adolescent treatment supporters who are HIV positive children and adolescents aged between 18 up to 24. They are trained and mentored as peer counselors, and this model is being integrated within the Ministry of Health and Child Care. So up to December 2017 in Zimbabwe, we are looking forward to have about 1,056 cats in 51 districts, and the model has been scaled up as well in southern region countries, 3 of them with support from the International HIV and AIDS Alliance. So on December 1, we sent out a bulk message to all the U reporters, and those 10 cats who were trained, they managed to respond to 2,576 cases, and this was basically around HIV treatment and services for HIV prevention. And adolescents and young people, they were responding, asking for the locations where they can access HIV services, asking information around HIV, what is HIV, what is AIDS, and how one can also get to transmit that virus. So this U report is being implemented in 39 countries, including India, but this varies from country to country on how best they would want to implement this. In 27, we then managed to get resources from UNICEF Zimbabwe because as a pilot at first, we were looking at free implementation. We didn't have any services. And we were also looking at someone who could partner in terms of making sure that those cats, they are getting stipend and their bus fares. So recently we received the resources from UNICEF Zimbabwe, and we trained 9 more cats who are now specifically looking at this system. So from December 2015 up to September 2017, the cats responded to 4,873 cases, and we closed 3,595 cases. By closing cases, what I am simply meaning is these are the cases which adolescents and young people, they'll be contented in the response. If someone asks for where they can access HIV testing services, we refer them. After referring them, they can confirm that they have accessed such service. So this also promotes confidentiality through anonymity, because the cats who will be responding to the young people, to the U reporters, they will not be able to know the name or the phone number which is being used, and the other way around as well. So we use unique and anonymous identifier codes. For instance, we have 3B34A0. It's a phone number which can be known by the system only, but the people who will be communicating, they don't know exactly who is this person. So this is randomly and uniquely generated, and we have free and frank discussions on sexual reproductive health, as well as HIV and AIDS is concerned. So we can discuss various issues, from sex issues, from masturbation, from issues around sexual reproductive health, because of that confidentiality. So in Zimbabwe, so far, the system has registered about 56,000 people, and of these, 51% are adolescents and young people between the age of 15 to 24. So as an organization, in terms of our way forward, we are planning to scale up this innovative to 2 other provinces, depending on the availability of funding, because we are having cats, and these cats, they also need stipends, they also need bus fares. So initially, we developed a mobile application which was focusing much on adherence, and for adolescents who are living with HIV were trained by UNESCO Zimbabwe, who also supported us on coding. And of late, when we tested it, we realized that there was so much work which needs to be done. So VIV Healthcare is also working on a positive action challenge on innovative solutions to transform the lives of adolescents and young people living with HIV in Zimbabwe. And we're also going to be continuing on online case management to engage the community on HIV testing issues, as well as supporting the 99 targets through differentiated service delivery, because our understanding is that adolescents and young people, they are different. It's not a one-size-fits-all, and in terms of the interventions, we need to tailor-made according to what they can also be contented with. Thank you so much.
That was terrific. Thank you very much. We have time for questions. You were extremely efficient in your presentation. I'll start off with a question. There have been many studies of different programs that have used mentors like this in different ways. And in pretty much all of them, if people looked, there was a huge positive benefit to the mentors in terms of their increased knowledge, comfort, feeling of their own personal efficacy. So is that something you've looked at, or do you have an impression about that?
Okay, so the Shandiri program, the way how it works, we will be having the adolescents and young people as the cats and the beneficiaries as well. But within the AFRICATE organization, there are also mentors. And what we discovered of late is that when the mentor is going somewhere for trainings or maybe for their presentations, there's also need for that young person to be there so that their voices can also be heard. Like for instance, myself, I am a young person from the Shandiri program. I also work there as the communications officer, and in terms of the knowledges, we would want the staff members and the beneficiaries as well to have the same knowledge.
Mohammed Isam from Egypt Book Council. Really thank you for your presentation. It's a great work. Because I have a similar experience in Egypt. We are working in an online website. It was provide counseling, and it was a really huge success. We have responded to 40,000 questions, but we always face a problem. What's next? Because if some adolescent or young people send us question, I need to go for an HIV testing, but we don't have services like offline services which provide a good and trusted services. That's why, like, both in social media and using social media is a very effective and very it's easy and cost effective, especially lacking funding for HIV/AIDS. But it have been combined with offline services, and so it doesn't work alone. Thus, we have to state this. So, thank you.
Okay, I think maybe just to slightly comment on that. Of late, we then realized that there's also need for these two interventions, the online and the offline, to complement each other. But in Zimbabwe, what we're also looking at is the access of internet services to adolescents and young people in the rural areas. Because as we are speaking right now in Zimbabwe, there are areas where radio stations do not have signals. There are areas where TV stations do not have signals. And the cell phones as well, sometimes they can have access to the network when they visit a particular area, which is also known for having such services. So that is also the other thing which we were also looking into. But with support from VIV Healthcare, we are also going to be developing an innovative digital solution for our adolescents and young people.
Thank you very much for your presentation. Very interesting work. I just wondered, so I mean you already have high cases that you're closing, and then the small percentage of cases that are not closed. I wanted to know whether there's any form of follow-up or referral to those young people. And I mean, so double question, I guess. And also because, I mean, it's a good thing that you're using the cats to respond to questions. Are there other professionals that could be maybe available to do that? Because then that might close the gap between the closed and the open cases.
Okay, so I will start to respond on your question around the cases which are not closed. So we refer to the other services because us as an organization, our strength is to program on adolescents and young people living with HIV. We come across with different cases on child abuse, issues around empowerment, and we refer to the other guys who have access to the dashboard. So what we then do of late is to make sure that if they respond to us or that young person respond to us saying that they have this service, then we are able to close that. But if we haven't received such information yet, it will be a difficult situation for us to close because at the end, what we are much more concerned on is issues around quality. And then on issues around professional counselors, the Zhandiri House, where adolescents and young people refer these cases to, they are trained for 10 days on counseling and other services. They do their attachment in the community and at health facilities. And at that Zhandiri House, where the IT lab is, there are also counselors, professional qualified counselors, who can also respond to their cases in case they have a challenge. And they also have a WhatsApp group where they can also share information or questions with the other service providers where they can also get some of the responses. So they are not working alone as an independent cadre, but we also work with the Ministry of Health and Child Care from Zimbabwe.
Another question? Oh, two more. Good. We'll get you, don't we?
Hello. Yeah, thank you for a very nice presentation. Just a quick question. I was just intrigued whether you kind of faced any challenge in terms of parental consent or the stakeholders coming into picture when you're using such a platform to reach the young adolescents, especially when it's the early adolescent age group.
Okay, so at the moment, we haven't received any, maybe some of the challenges of some sort, but the key challenge which we are then facing is that the U-Report system, what it needs is a real-time response to the user. So in terms of the resources, like what I said earlier, on this case, they are also adolescents. They also need to sustain themselves in terms of stipends and bus fares. So that's the key challenge which we are facing. The resources which we received, they are ending by end of January 2018, and we're still trying to think on what exactly are we going to do after that one. So that's the key challenge which we are facing. Those stakeholders, they also assist us in making sure that many young people, they also register on the system.
Okay. Then we've got a person right there.
Thank you for your wonderful presentation. I'm from a small state in northeastern part of India called Mizoram. We do our work with the adolescent population, and we have our own set of peer volunteers, but they are not HIV infected. They are young, 16 to 19, and we train them but we cannot do a full-fledged training because they are into their schools. So from our experiences, these peer volunteers, they often encounter cases which require mental health issues, intervention and all that. So I'm just looking at your presentation, and the cats that you have mentioned, are they able to deal with these kind of issues, or you have a backup plan where you link them with professionals, those kind of things? That's what I'm asking.
Okay, thank you so much for the question. So in our context with the cats, they are a community cadre. They do not work alone in the community, and to us, the online system seems to be a community. So they work with the village healthcare workers, with the case care workers, and in terms of other cases which they might not be able to be working on or to deal with, they then refer either to the Ministry of Health and Childcare, to the Ministry of Labour and Social Welfare, as well as Childline. And in terms of that referral to us so far, it's something which has worked on so well, because as the case, they are young people. As an organization, we also have our demarcation in terms of cases.
Thank you. I think that's our time for question. I would like to just ask a favor of you. There are members of the audience who are from high-income countries where teenagers might have 5 or more gigabytes of data a month. Could you just quickly explain to them why SMS is a more effective tool?
Okay, so the short messaging service channel, it's an effective tool because from our understanding, we are saying each young person has a mobile phone. Be it an ordinary phone which does more of texting and sending messages and receiving calls. It does not require any data, but from our end, as the people who are implementing this initiative, we pay for the bulky SMSs, and from the end user, it will be free. So if you would want to maybe explore more on this initiative, we can also chat after this discussion, but my recommendation is that, like what I alluded earlier on, adolescents and young people, it's not a one-size-fits-all. They are different in their own making in terms of information dissemination. Some they can access social media, some they can access pamphlets, but there are some areas where they cannot access all those things. So in brief, short messaging services, they are quite cheap for the young person because we pay it as we have resources, and the young person without any resource, they can communicate with us.
Thank you very much.
So our next speaker is Madam Sumitra Dal Samanta, and the title of the presentation is Examining the Feasibility and Acceptability of Mobile-Based Interactive Voice Response System for Delivering Information on Reproductive Health in Rural India. You have the word.
Thank you so much. Good afternoon, all of you. I am presenting the topic on examining the feasibility and acceptability of mobile-based interactive voice response system, that is known as IVRS, for delivering information on reproductive health in rural India, from Mamta Health Institute for Mother and Child, New Delhi. Globally, as we know, India contributes to a high burden of maternal mortality and infant mortality. 25% of the female population in India within the age group of 15 to 24 are married before 18 years of age. 40% out of them belongs to the economically marginalized communities. 1 in every 6 women in the age group of 15 to 19 is a child bearer in India. Hence, it is important to link them into the national RMNCH plus A strategy, which is based on the continuum of care approach. With the expanding mobile-based technology and the use of mobile, it is better to use the mobile as a tool for reaching the unreached people for public health services, especially in the reproductive health-related messages. Our national RMNCH plus a strategy document also highlights the importance of the mobile-based health service. The objective of this particular study is to examine the feasibility and acceptability of the mobile-based interactive voice response system on delivering reproductive health information among ASA and young married women. Here, ASA is basically a grassroots level health worker who is catering 1,000 population and for one particular village. For this particular study, we have taken 2 blocks as a pilot intervention, one from Uttar Pradesh and one from Rajasthan. We have taken 200 ASA and 1,000 young married women from the age group of 15 to 24. For this particular study, we have taken 20 focus group discussions catering of ASAs, young married women, pregnant women, lactating women, and also we have captured the MIS data of the IVRS. This particular slide shows the implementation process of the IVRS. There is a toll-free number which was provided to ASA, and then ASA communicated that particular number to the young married women for getting the information. There are 3 different sections in the IVRS. One, there are basic information, and the informations are relating to adolescent care, preconception care, antenatal care, postnatal care, and newborn care. Next, there is a infotainment section, that is basically information given through the in a dramatic way or in a slogan or drama in that section. Third, there is a tips for the counseling, which will encourage the counseling skill of ASA. All these data are stored in the central server, and from there we do harvest the data in a periodical basis for our analysis purpose. Coming back to our objective, feasibility and acceptability are the 2 major components that we want to see from this particular study. We see that the feasibility through our call rate and through the focus group discussion. Our call rate shows that there are almost 5 times higher call rate over the 15 months of pilot study of this particular intervention, and with an average of 660 calls per month. And we found that there are entertainment section are more popular in comparison to the general information section, because this is more dynamic and people are getting more entertainment through that. Cost-wise also we found this is feasible, because mostly the establishment cost is required for this, and with very less maintenance cost. And for the beneficiary point of view, this is free of cost. Our focus group discussion with ASA shows that there is an enhancement in the existing knowledge among the ASA. As a result, the efficiency of the ASA to work on the reproductive health and to giving the input to the young married women become higher. ASA revealed that in the FGD that if she could not able to make the young married woman understand about any particular reproductive health related subject, then she connect to the young married woman to IVRS number and make her listen to, so that it will be more convenient for both of them. Similarly, for the young married women, they reported that initially they had some hesitation for using the IVRS and its related technology, how to use IVRS, because in most of the women in the rural, they don't have either mobile or they are getting mobile from any family member or somebody. So in that case, and there are some options like it's something like a call center, like press 1, you can hear this, press 2, you can hear this. So for the purpose of compatibility, we have kept only 3, as I have mentioned earlier. So earlier, in the initial stage, young married women also felt discomfort with using the IVRS technology, but gradually they could able to use that with a very comfortable manner with the help of ASA. And they're happy about this IVRS as they stated in the FGD, because they are getting information where ASA is even not available, even their family member could not help them on relating to their reproductive health related issues, and most of young married women are in an adolescent stage. Even when there is no mobile phone with the woman, she can borrow a mobile phone from anybody else and she can hear it, because it is free of cost. We see that the IVRS technology has gone beyond the ASA and young married women. It has reached to the family and community, so it shows there is acceptability. And in that way, we can also see that from our MIS data, that there are some calls and also some questions that we're receiving in the MIS, that is, we're getting from the male members from the community. So it has gone beyond the ASA and young married women. As a result, when a community is listening from the IVRS system that what is ASA is telling, the same thing, so there is a better reliability and better acceptance level for the ASA by the community. Overall, our participants of the focus group discussion expressed that they liked the IVRS because of its confidentiality, and this is very easy to get the information on the reproductive health related issues, whatever they are required, and they can get it at their doorstep and without depending on anybody and from anywhere, from any corner of her family or from the room. We also received some feedback that is there should be instant expert advice, because we have a facility in the IVRS that there should be expert advice, but it is not instant. This is for the 48 hours. Within 48 hours, we give the answer. So they had a request for their suggestion was to there should be instant expert advice, and also there should be inclusion of menopause stage. Being an implementation person, when we started designing this IVRS, even we forgot this, we have not kept into the account for this menopause, but this came out of the community from the, from the young married women and from the ASA that there should be a menopause issue. From the FGD, we can conclude that there is a need of the upscale of the IVRS. We need to scale up the IVRS strategy for the community, especially which is very outreach, where skilled and committed health workforce are very limited. Further, this technology in the community, this technology could empower the rural community, because they can get the basic preventive and curative measures for their reproductive health issues. Because this IVRS is just in a missed call away. Recently, we have completed this pilot intervention in our study area, and we are continuing with the end-line evaluation. This is going on, the process is going on. And similarly, at the same time, we are advocating with the government for the sustainability of the IVRS, and government also included, because the ASA belongs to the system, and the government is already noting down the IVRS number in the maternal and child health card of the women in their system. So thank you so much for hearing this.
Thank you for another example of the use of technologies in public health. I have a general question for you and the two former speakers. In fact, one of the interests of these new tools is that not only do they allow one to, reach population, spread advices, information, but they potentially also represent research tools. So my question is, did you foresee, and this is also for you, to collect and analyze the kind of information that is requested by your audience, so that you may ultimately focus the training of people more, taking into account the profile of the questions that come. Do you understand my question? But this is, if you want to briefly comment, because we need other questions as well. Thank you. So please.
Should I answer this?
Yeah. Would you like to answer?
Yeah. In our IVRS, actually, we have some baseline and inline data. In the meantime, we have two phases of focus group discussions. We have two phases of focus group discussion, which I have already just presented. But in the same time, periodically, like in the 3 months interval, we had some feedback from the community. That is, our target group is ASA, and our target group is young married women. That is from the preconception care, which is 15 to 24. There are ANC and PNC group. So we get the information from them, and I have presented that they have the feedback in that way.
Any comment? Very short. Microphone. Just grab the microphone here.
Thank you. So we, not in this study that I presented, but in one of the studies that we conducted across Nigeria, we asked questions about what kind of information adolescents would like to know, what they would like to have, and where they would rather have it from. Is it from parents, from social media, and presently, what kind of information do they seek for on social media and how would they like it to be presented. Also, in another study, we asked them even on the social media platform, which ones will they prefer? Is it WhatsApp? Would they prefer Facebook? Would they prefer Instagram? Which ones would they prefer across? So we have data on that.
Thank you very much. Another question. Over there and over there. 2 questions, not more. Please. Well, okay.
Okay, thanks very much. I was interested to know what kind of resources you needed to look at the comments that were given from the young people and the ASHA. You mentioned in one of your slides that when people, I guess, leave messages, then you can look through. I was curious to know, is that automated or is someone manually going through that? And how does that work in terms of going forward?
Okay, we are not going exactly the manual because this is a FGD findings. That's why it is we have recorded and we have presented this. But for the IVRS system, there is a central server. There is a central server that need to be established, and there are experts who are, Gram Money is working for us for that, to establish that server. And the toll-free number that has been provided to the particular community, they will call to that particular number, and the call will be automatically disconnected, and a callback will come to them from the server, so that there will be no cost for the beneficiary. And the establishment of this particular server is there, that is a one-time cost and with a little maintenance cost. And all the data relating to call timing, and in which particular segment the more calls are coming, what is the average call duration, which section is liked more, everything is in a database, and in a daily basis data is, you can see the data on a daily basis. But in our case, we are harvesting data on a monthly basis.
Hi.
Okay.
That was a lovely presentation. Yeah, here. Just one.
Well, we had this gentleman before, I'm afraid, so if you can, and you can discuss afterwards.
And
okay?
while you're getting that microphone, I'd just like to say there's a gentleman at the front who seems to be recording everybody, and that's not from IAH. It is for IAH? Okay. So just if people don't want their video to be used, just please make sure you let him know, just so people know that there is taping, just in case you're fugitives from justice or anything.
Okay, please.
Hi, my name is Samir, and as I understand, this was a pilot. So my question is, well, it's in 3 parts, but let me ask you the bigger question. Did you refer to similar programs, IVR-based, that have been done in the past, maybe for scale, to inform your own pilot? And could you give me an example? And secondly, what was your motivation to do it in those particular places that you have rolled it out? Because there are examples of much larger scale.
Quick answer, because
you are right. There are much larger scale IVRS interventions are there in India especially. But in the Rajasthan and in UP where we are working, so exactly IVRS where there is a pre-conception care and the adolescent particular subject is nowhere you will find in the continuum of care approach segment. There are Kilkari programs, there are programs like Mobile Kunji in the UP, but it is not in the Rajasthan, but in the UP, but you will not find the pre-conception care. In my earlier slide, you must have gone through that pre-conception care is a missing link in the whole RMNCH plus a strategy also, because we are targeting to the adolescent and we are targeting to the ANC onwards. But there is the missing link, so once the adolescent is married, so she is a missing kind of group. So in this, their focus is more on the pre-conception care, which is from 15 to 24, the adolescent group is also covered.
Okay, thank you so much. Again, if you have further questions, we have time after the session for close other discussions.
Thank you so much.
This has been great. I'd like to ask our giant team for our next paper to come forward, please. The title of the paper is Translating Research, the Experience of Using Social Media to Amplify the Lancet Commission on Adolescent Health and Well-Being. And this is being presented by Christina Bennett, Molly O'Sullivan, and Kiki Lomo Taiwo. I hope I got that right.
In 8 minutes.
Okay. We'll be quick. So we've been introduced, and what we're going to be talking about today is the experience of using digital media to promote and amplify the messages and recommendations from the 2016 Lancet Commission report that you will have heard about yesterday from Professor Patton. And our presentation is going to focus on how we use digital platforms to help us communicate to a much broader audience. The big question we grappled with was, how does one go about communicating the content of a 60-page, incredibly dense report to people and to multiple audiences, including but not limited to policymakers, young people and academics. Communication needed to be in a very different form and language than the academic language used in the report. We wanted to take the messaging from the one-to-one communication of a written report to a much broader audience via social media, and here you can see a number of our word clouds from the last 3 years of digital content. So we asked ourselves, why use digital media? Why use online media at all? And some of the answers lie in the fact that today 3.8 billion people use the internet, 3 billion people use social media, and nearly half of these on a daily basis. In comparison, the Lancet circulation is much smaller, and while their numbers are fantastic and their impact factor is massive, the Lancet readership group is only part of our target audience.
So why social media, you would ask? Dakshita, my fellow youth commissioner on the Lancet Commission, highlights the necessity of having and using social media to reach the youth advocacy demographic. As one of the youth commissioners, I believe one of the ways youth advocates can maximize traction using social media is to stay consistent and timely. We must go beyond just putting information out there, but spreading content that will make meaning in the lives of those we are sharing it with.
Thank you, Kiki. Between tapping into the internet user base of 3.8 billion and making sure we used media that was relevant to our intended audiences, how did we decide what to use? In the end, our decisions were based on resource allocation and pragmatism. So what did we do? The main platform we used from the beginning was the website, which is used as an information platform about the Commission, as well as hosting a dedicated blog. The blog is used to promote relevant work in the global adolescent health and wellbeing space and can be subscribed to via the website. The content focused on the work of the Commission itself, things the Commissioners were doing, and all of the other things that were happening in the adolescent health and wellbeing sphere. At the same time, we implemented some limited content on LinkedIn because this allows Google to augment the level of where we are on Google searches. In May 2015, we decided to add a Twitter account to begin to grow the audience in advance of the launch of the Commission report in 2016. We gave ourselves a year to build this audience. It wasn't long enough, and we were very inexperienced. We needed much longer, and we needed a much more cohesive strategy. We did achieve the following by following adolescent health and wellbeing focused organisations and constituents, liking relevant messages, I'm sure you all understand this, and where appropriate, retweeting. Additionally, before the launch, we started a campaign of tweeting in the relevant content areas of what was coming in the report without breaking the embargoes. The Lancet embargoes are very strict. The Commission report itself is hosted on a microsite of the Lancet, and we worked with the Lancet communications team to ensure that we were not competing and dividing the user base. Rather, our website would direct the users to the best location for the different components of information. And especially as the microsite was not active until on the day of the launch, it was important to ensure that all was ready as the launch embargoes were lifted.
As seen in the red table, the Lancet Commission on Adolescent Health and Wellbeing microsite is the most viewed microsite on the Lancet's website ever. The green table highlights how far that reach has been, and in the 16 months since publication, our Commission report has been cited 154 times. On the screen are some statistics from the London launch event. Through a combination of partner outreach, influencer engagement and careful planning, on the day of the launch and the day after, there was an incredible rate of social media engagement. During the 2 days, tweets that used our hashtag LancetYouth reached over 7.7 million people. If we had relied solely on print or the event itself, we would not have reached those staggering numbers. Analytics built into our digital platforms, so website, Twitter and blog, track our social engagement. The Commission's analytics were used to track how we are progressing, in other words, to understand what tweets, what blogs, what website pages were popular, and to understand who our current audience is. Currently, 70% of our website and Twitter users are female, 60% are aged 25 to 44 years, and 60% of our website traffic comes from high-income countries. Knowing this information as we move on to the next phase allows us to target our communication more directly. We have tried a number of methodologies to engage with audiences, and we will continue to trial these and assess the results via our analytics. We hosted a 1-hour Twitter chat, which was an interesting and exhausting experience, as noted here by Professor Susan Sawyer. Despite a relatively small number of contributors, 564 tweets were sent within the hour and 389,000 people saw the tweets. A number of our commissioners have participated in webinars. We had one in February this year that had 400 participants, which is a fantastic turnout, and a further 2,000 have seen the video on YouTube. Additionally, the work of the Commission has been presented at conferences and events, both globally and locally, which were again promoted via our website, Twitter and blog. We have also used visual media, including infographics, GIFs, images and videos to promote the messages of the Commission. For us, tweets that included visual media as well as using a hashtag were always popular with our followers. So too were tweets that promoted events, not just ours, any adolescent health events, and provided information as well as contained links to the evidence.
So what have we learned? If you have quotes from influential people that speak to the relevant content and constituents, use them again and again. Plan and evaluate to develop digital content, but also use themes from your top tweets, and additionally allocate sufficient time to review, interpret and implement analytic findings. As you do this, your communication strategy will evolve with your work. Don't forget to train everyone in the team. And in summary, digital media has been a valuable tool in extending our reach, but it requires time and care for effective messaging, and as George Patton reflects, we would not have got the message out without it. Finally, I'd like to acknowledge the many teams who assisted with the online presence and social media, and especially to acknowledge the work done by Molly, my co-presenter today, who, when she came into the role, like me, we had very little experience in using these medias. And to finish off, one of my personal favourite quotes from Ban Ki-moon that we have used many times.
Thank you.
So that was amazing for 3 people that you were right on time. Thank you very much. Really great presentation. And just to let you know, I tweeted it while you were talking in case you thought I was just checking my email or something. So questions from the floor.
Thank you. It was really nice listening to you guys. I just have one question. How much of this reach was a paid reach?
None. We haven't actually gone into the paid promotion yet. Obviously, as we move into the Standing Commission, we are having discussions, obviously, about to use Facebook to implement, and we are very much aware that if you, especially with Facebook, that obviously paid promotion may be needed, but to date, nothing.
All right. Do you feel that there was a challenge there in terms of not using organic reach?
Absolutely, it was a challenge.
Simply yes. Yes, it was a challenge. I think for us in particular, the difficulty, and as Christina highlighted, that if you do go down the social media pathway, there seems to be a lot of thinking that social media is easy. That, you know, just create a Twitter account, just write those tweets. But the amount of time to develop content is really, really underestimated. So for us, our learnings would be perhaps to have actually spent a bit more time creating the content and thinking about it, as opposed to kind of, oops, tomorrow's World Youth Day. I haven't planned anything, I haven't written anything, and kind of those last minutes. So that's really the big thing, is to have that little bit more time and care to do a bit more planning, which we all need to do in many.
Hi. Hello, good afternoon. Hi, good morning. I am Einstein from the Philippines. And I really admire how you were able to convert your offline presence to online presence. But have you had any experience in converting them vice versa, online to offline action? And also, I'm looking at an angle where you can have it, you can sustain those reach in a more membership base. Do you have any plans in doing that?
Do you want to answer?
In terms of the offline reach, I mean, you would have hopefully heard the plenary by Professor Patton yesterday. So there's been an enormous amount of work. He has spoken all over the world about this, as have all of the other commissioners. So we were, in fact, just backing up the offline work. So if we knew that anybody was talking about this anywhere in the world, we would be tweeting about it and trying to make sure it was in the right timeframes and things like that. So I don't know if that quite answers your question. No.
I've got on this side, I've got a microphone.
Yeah.
Hi. Hi.
Sorry.
So, thank you for that. So, the commission launched the report in London, and then 2 months later, I think, in Washington, D.C. So I'm wondering if you learned anything from the London launch that you then applied to the outreach a couple of months later, and/or how many new followers had you gained in London who then were able to multiply the reach a couple of months later?
Yeah, no, definitely. By the time of the London launch, as I was saying with Twitter, we had about 500 followers. And obviously after the launch in London, that definitely had spiked. And then in regards to the content, we obviously had the time to develop content for the London launch, and that was very much in terms of with the messaging and some feedback that content was slightly tweaked, again, slightly different audience within Washington, and we had redone the content, but obviously some of it was still the same. We still wanted to say, we're here, this is our report, please read it. And it was live as well, so it was quite difficult, obviously, with the time zones. I'm in Melbourne, the launch in DC. So there are a number of great third-party programs like Hootsuite, Buffer, that you can obviously schedule all your tweets to go out. But we definitely relied on some of the commissioners that were there to help obviously retweet and do the live tweeting from the events. But definitely we saw spikes. After every event, there was always spikes in our followers, as increase in those going to our website from the traffic. So obviously every time it's promoted, you get that little increase.
Great. Thank you very much.
Thank you.
So we come to the next presentation, which is again a duet or a duo, if you like. I invite Nicole Ippoliti and Sharon Bowe-Pendra to come on the stage. The title of the presentation is Cyber Girl in Rwanda, using human-centered design to develop digital and SMS sexual health and employment tools.
Thank you, Pierre. Get to the podium without tripping and falling. Check. My name is Sharon. I'm the Executive Director of YTH, Youth Tech Health, and I'm here to present about a program called Cyber Girl that we're implementing in Rwanda, along with my colleague, Nicole Ippoliti, who is with YLabs, our collaborator on this program that's funded by Packard Foundation. So we utilize human-centered design as a key approach and methodology to design this program, and some of you might be familiar with this approach, but for those who are not, I'm going to take 10 seconds to give you a very high-level picture of the approach and methodology. So human-centered design obviously puts humans and users at the center of the design. It starts with a question rather than the solution, and in order to answer that question, we go through a process of design research where we use ethnographic methods through interviews, observations, etc., to gain insights and develop inspiration that leads to the ideation phase and helps us brainstorm a lot of solutions. And then finally, based on the ideas that we select, we develop tangible prototypes that can be taken into the community and tested, and we learn from that process, come back, iterate, get better, and finally lead to the formation of the final product. So when you're working in Rwanda, there are several things that are important for us to know, one of which is there's definitely economic progress in the country, but we realize that young people, especially young women, were being left behind. There's high degree of mobile phone penetration and technology use, so there was opportunity there, as well as understanding of what's happening or what was happening around the sexual and reproductive health world, with 1 in 10 girls reportedly having transactional sex, low numbers of condom use in last sex reported, as well as low contraceptive use among in the community. So with this understanding, we dived into the design research phase of the project, and we interviewed and talked to or engaged with almost more than 400 young people, providers, researchers, stakeholders, parents, etc. And through this process, we developed several key insights that Nicole's going to share with you.
Thanks, Sharon. So all of this design research gave way to 4 major insights that shaped the future of our program and the future of our design. And the first one was that sexual education in school is largely limited to condoms and abstinence. We found that existing materials were really based on scare stories of the negative consequences that would happen if teens had sex, without giving any practical information about where to access contraception or how to use it. We also found that healthcare providers felt that it was their main role to keep young people abstinent, that increased sexual education would give way to greater promiscuity, and they were very reluctant to provide them with any kind of contraceptive services or counseling. We also found that providers were heavily biased against hormonal methods and had pretty stringent ideas about the kind of girls that would qualify for these methods. And not only was talking about family planning or reproductive health heavily stigmatized and taboo, but we also learned that young women had shockingly low knowledge about their own bodies, periods, and puberty, and regardless of age or socioeconomic background. So, you can imagine that if young women don't know what their periods are, it becomes increasingly challenging to talk to them about contraception. So this was very critical for us to take a step back and reevaluate our health curriculum, understanding that we'd have to move beyond family planning and HIV information to also include lessons about puberty and menstruation. And then lastly, we learned that having the skills to get a safe and lucrative job is important not only to youth, but also to their parents. Because of this, we decided to take an integrated approach in our programming by contextualizing pregnancy prevention as a means towards ensuring the potential for entrepreneurship. By framing the program in this way, we were able to get parents to agree to a more comprehensive SRH education as a gateway to safeguarding their children's economic futures. And based on these learnings, our programmatic aims were very narrowly defined to 1, deliver trusted, accurate, and confidential SRH education that both met the needs of girls and was also acceptable to parents, build the youth financial capabilities, and 3rd, establish a referral network to youth-friendly providers. And this is a photo of our initial design. It was a mobile app that is simple, heavily white and pink, and incorporated both job skills as well as an avatar who would direct youth to a clinic or answer questions that youth had about health. And we learned several things very quickly as we started to prototype. First, we learned that combining sexual education with employment skills did, as we expect, make it more acceptable to parents and more interesting to youth. Health is not always at the top of their minds, but their economic futures and their education is. And we also learned that this prototype in this iteration was not going to work. The design, first of all, did not look and feel Rwandan. White is associated with death in Rwanda, so we learned quickly that we needed more vibrant visual designs. The visual nurse character looked like a peer, and the feedback from youth was that they wanted someone more professional, someone to whom they could aspire. The third was that the content and sequencing was not exactly aligned with what users wanted to know. And lastly, and very importantly, having a very refined and polished prototype that looked like a near final product was very difficult to solicit honest feedback from users about how to change it.
So now that we knew what was not working, we were able to revise our design questions and go back into the community to continue our design development process. And there were several new questions that we developed that helped us, that helped guide what the next stage of the progress is going to be and what that would look like, including what was the tone, what was the look and feel of the solution that would really resonate with young people. What were the specifics of the sexual and reproductive health information that young people needed and required? And then how do we understand and segment the different parts of young people that we were working with so that we could address issues such as differences in access, differences in literacy and education? And then finally, within the employment aspect of the program, what were the specific skills that they really wanted to pursue? So with this understanding, we went back to the community, and as we did that, we also realized that our earlier idea or understanding that young men or boys were also a community that needed to be addressed was further highlighted because boys, we discovered, were, just like women, less likely to have understanding and information around sexual and reproductive health. They were getting most of their information through online porn as well as other unreliable sources. And then they were also very interested in learning about technology and other skills to be able to get employed. So this is an example of how we went back and redid our prototypes. So as Nicole was mentioning earlier, our first prototype was a very fleshed out, sophisticated prototype, but we went back this time around and actually cut out paper dolls and worked with our youth collaborators to go to the tailors and find some local fabrics that could be brought back. And then we played around with that to come up with the right look and feel for what the avatars on the solution would look like. And so we are at a stage where the future of the program, the strategies have been defined. We have 3 key strategies how the program is going to work. The first is around Teen Guide to Success, which uses tablet and printed material around sexual and reproductive health and employment. We are working to develop avatars called Baza Mutoni and Baza Ntwali, through which young people can seek information and referrals through SMS and IVR, and then Cyber Nurse to provide reliable information to young people through culturally competent providers. The anticipated outcomes are obviously improved employment skills, improved information and knowledge around sexual and reproductive health, and improved access to culturally competent and trained providers. This is just a snapshot of what some of the final prototypes look like. As you can see, it's highly colorful. It has been developed by young people in collaboration with us. There are a lot of quizzes. There are a lot of interactive activities that have been designed. The look and feel are what young people would resonate with. And we are moving into the phase of turning this prototype into an actual product over the next 12 to 18 months. We are also continuing to work with providers to build that prototype, and we are also engaging young boys to build a solution to reach them as well. And then we hope to achieve all of this by 2019, where we plan to move into the evaluation phase.
So why does this experience matter? If there's one thing that you walk away from this presentation with, let it be this. We need to engage young people in the design and implementation of adolescent health programs. We believe that human-centered designs offers a creative and deeply participatory approach towards co-designing and prototyping with youth for better program design and more tailored solutions. Human-centered design takes the risk out of designing solutions for scale. We developed confidence and tested assumptions with over 400 beneficiaries and key stakeholders before launching. We also shifted massively from our original idea. Test your assumptions and be open to failing and pivoting rapidly based on what you learn from your users. It will make your program stronger. We also need to start designing programs with a question rather than a solution. To design for this generation of young people whose needs are rapidly changing, we need to work in partnership with them, understand their needs and aspirations, and involve them deeply in the design and implementation of health and development programs. We want to just thank all the young people and their communities who worked with us on our team to design this program, and special thanks to our donor, the Packard Foundation, for believing in and funding this work.
So thank you very much for this inspiring presentation. I found it funny that you called one of your devices Ask Juliet, because around 20 years ago, Harvard Medical Center set up a website that is called Go Ask Alice. So it's
Which is amazing,
It's,
by the
it's
way.
amazing. I have, if I dare, a provocative question. Your aim was to improve skills in the field of sexual reproductive health, but as well to focus on employment. And to build on what Bob Bloom said a few minutes ago, and this is provocative, forgive me, what does it mean to empower, because clearly you empower these girls, if you know in advance that they have very poor perspectives anyway in the field of employment? Do you see, how do you cope with the fact that you want to improve their capacity of entrepreneurship, I would say, but on the other hand, I can assume that in Rwanda, the perspectives are still in some region very poor. So you see my question, how do you, combine? How do you match these two?
Yeah.
Which was the comment of Bob Bloom a few minutes ago.
I think there are several things to keep in mind. One is I don't think there's a silver bullet to the whole solution. What we're trying to do is apply a proven methodology to really figure out what is the best solution at this stage and what we can do given our resources and the local context. So within that local context, we discovered that this solution would be more applicable and probably have a higher probability of success in urban and peri-urban areas where there is existing businesses and people who are really interested and excited about having a social impact and engaging with programs such as ours, where they can actually work with young people and create a pipeline for internships, apprenticeships, and potentially employment. And then I think technology is continuing to play a very crucial role, because now we can do things such as online training for coding, for graphic design, etc. These are things that didn't exist or weren't available several years ago, and now we have a window of opportunity where we can use these elements to really mobilize the community.
Okay, thank you so much. 1, 2 questions from the floor. 1, 2, and we will stop. 1, 2. Please.
Hi, thank you for that amazing presentation. I really loved all the graphics. But I was just wondering, so of course human-centered design, I'm sure the process has some challenges. And I was wondering because, when we talk about young people or adolescents, they're not a monolith. And so not everyone likes the same thing. So I was wondering, how did you guys really arrive at that consensus that this one thing actually works for everyone?
I think that's a remarkable thing about really investing in the formative research stage. I mean, as I mentioned, we spoke with over 400 people. And so at a certain point, you're going to reach a saturation in your responses where you continue to hear the same things over and over again. And what we heard is that, youth want tangible skills for employment in order to secure their economic futures. They want trusted, confidential, accurate reproductive health information that is free from bias. They want to be able to be linked towards mentors in their community. They want access to, provider bias-free health services. These are sort of like the cross-cutting things that we learned. But again, we only really achieved that after speaking to over 400 people.
Well, first I'll congratulate you on this whole, it was quite nuanced as I saw. You spent a lot of time working on the design and all that, so congratulations on that. My question is about cost. Your opinion on cost. I see this as a pilot supported by a foundation, and now technology is getting cheaper, free if you may. In the very near future, developing something would be absolutely, I believe it would be free. So where do you see you could develop this for free? So just to give everyone here an idea of where that is heading in terms of financial resources and of course the connected struggles are.
Okay.
Absolutely. I think you're absolutely right. I've been working in the field of technology for a few years now, and one of the key things we know about technology is that when it's created or launched, it's expensive, but over a period of time, it tends to become really cheap and sometimes even free. We are hoping that will play a key role as we continue to design and implement this program. At the front end, as we are investing in building the solution, we are very careful that for the user and the final product, it is always going to be free and easy to use for the consumer. The cost typically is what we incur in design development, evaluation, maintenance, all those good things. But having been doing this work for a very long time, we have identified ways on how to be really cost-effective and cost-efficient as we are designing these programs. We cross-collaborate with pro bono folks who actually come with us and help us design. We have a bunch of really excited, interested Google experts, for example, who've been working with us to actually code, hopefully, some of the solutions that we'll be coming up with. So we are very conscious of the cost and trying to make sure that whatever we develop is very cost efficient.
Great. Okay, thank you very much.
Thank you.
Our last paper of the day today is being presented by Fiona Robards, if you'd like to come up, and it's called How Can Health Systems Best Support Marginalized Young People in the Digital Age? And it's obviously a very important topic. Thank you.
Thank you. Well, it's wonderful to be here at the 11th World Congress, and I want to begin by acknowledging my co-authors, who are the chief investigators of the Access 3 study. So Access 3, I'll just go to the first slide. Access 3 is a mixed method series of interconnected studies from New South Wales, which is a state in Australia. We explored how young people access, navigate and experience the health system, focusing on how, young people belonging to 5 marginalised groups. So Indigenous, young people living in rural and remote communities, homeless, refugee, and gender and or sexuality diverse. And it was funded by the state government to inform policy because there's limited information about young people's health system navigation, including their use of technology. So Access 3 is a multi-methods project that involved 4 studies. Study 1 involved a cross-sectional survey, which was both on and offline, with targeted recruitment of marginalised young people. And we achieved a sample of 1,416, with 63% of the sample belonging to one of the 5 marginalised groups. Study 2 was a qualitative longitudinal study. It involved 3 to 4 interviews over 12 months with marginalised young people. The 41 young people belonged to one or more of the marginalised groups, and 16 of the young people actually belonged to 2 marginalised groups, and 3 young people belonged to 3 groups. We achieved a retention rate of over 85% in this study. Study 3 involved qualitative interviews with health professionals. We interviewed 22 health professionals from a range of roles and services, and 41% were from rural areas. And Study 4 was a policy translation forum to make policy recommendations. And this one-day forum involved 64 representatives from academia, services, policy, alongside young people. We used a mixed methods approach to analysis using SPSS and NVivo software and grounded theory. So from the survey, cost, opening hours and embarrassment were the most significant barriers that would prevent a young person from visiting a health service. So confidentiality, which is previously thought to be the most important barrier, was cited by just 16.2% of the sample. So this pattern's different from our previous understanding that confidentiality concerns are the most common barrier. There were also some significant trends with age. For example, cost and opening hours as a barrier increased with age. So in the interviews with young people and professionals, there were 5 key themes. So the first theme relates to the importance of health literacy. In Australia, access to the internet is very high. However, marginalised young people were significantly less likely to have access. More than half of young people were using the internet to find information about keeping healthy and health problems they experienced. but marginalised young people were less likely to do so. However, we did find that marginalised young people very much want to learn more about how to navigate the health system, both through online information and school education. The second theme is the role of technology in engagement. So Google is frequently the first port of call for young people. Sorry, I've just lost my place. Okay. And checking out service websites is very much part of a young person's engagement with a service. They also prefer to make initial contact with a service and communicate using technology, and they value SMS appointment reminders. So the traditional access barriers are well known. They include transport costs, opening hours, issues with service knowledge. But digital technology brings new opportunities to overcome these barriers, particularly to be able to learn about and connect with services. Our third theme is providing welcoming and respectful services for all young people. Young people value an ongoing relationship and connection with health professionals they can trust. Most importantly, they want to be listened to and treated with respect. Sadly, marginalised young people also perceive and experience discrimination when accessing health services. Transgender young people feel discriminated against by healthcare systems, and they ask that health professionals are trained in gender diversity. Refugee young people experience language barriers and racism. But services can promote and recognise diversity, for example, by using welcoming signals such as rainbow stickers and Indigenous flags. Our fourth theme is about responding to the challenge of healthcare costs driving choice. So the cost of healthcare is currently the primary barrier for young people. Information about cost is important to young people because it drives their choices in navigating the healthcare system. But young people and healthcare providers are often unclear about cost, and young people primarily seek this information about cost online from service websites, but because they feel uncomfortable about asking. And doesn't Australia have a universal healthcare system, I hear you ask? Well, some services are hard to find for free or low cost, even in Australia. These include like specialist appointments, medications, pregnancy terminations. Other services are free, but they require good health literacy to access. So services that support marginalised young people to access free and low-cost services are valued. Finally, our fifth theme relates to health system complexity. So gatekeeping and bureaucracy add to system complexity. System rules and processes can be difficult for marginalised young people to understand and tolerate. Fragmentation of the health system, for example, the way the health system is divided up by health issue, leads to more complex healthcare journeys. And a lack of appropriate services and engagement contribute to system inefficiencies. So these are all wasted opportunities for early intervention. So in Study 4, the Policy Translation Forum, we develop policy priorities, and essentially services need to be turned on their head. Services need to reach out to young people. Professionals often expect young people to come to them and negotiate a complex set of processes. So services need to step outside traditional boundaries to facilitate connections, and this includes using technology more, being in the online spaces where young people are. Services need to be better at engaging and welcoming marginalised young people. Engagement includes staff attitudes, service environment, service promotion, and these can all be shaped via youth participation and an understanding of marginalisation and multiple disadvantage. We need to make navigation easier for young people moving through the health system. So follow-up can be really challenging for young people, and marginalised young people often need support to manage system demands and complexity. Assertive follow-up is part of supporting young people's healthcare journeys. The New South Wales Youth Health Framework was released in June this year at the Australian Youth Health Conference, and pleasingly it prioritises marginalised young people. It was informed by the Access 3 study and the Policy Translation Forum, and we now have a better understanding of how to support marginalised young people's healthcare journeys. There's an increased focus on health literacy, technology, navigation support and youth participation. So young people can be buffered against the inefficiencies, duplications and fragmentation of a complex health system via navigation support. Technology in particular brings opportunities to equip young people in their role as health system navigators and to make their journey easier. Thank you.
Thank you very much. I wonder if your finding about confidentiality is that the word has gotten out everywhere that we do provide confidential care. And
young people seem to have a much better understanding of confidentiality, and they say that health professionals do explain it to them.
Right. Could you just talk a little bit more about the embarrassment thing? I find that interesting that that's a pretty major barrier. While people are raise your hands at the same time if you have questions so that you can be getting the microphones.
Actually, I might ask my colleague to jump up and maybe respond to that, because I'm a bit stumped. Embarrassment. This is Melissa King.
Hello, hi. Hi. The barriers were forced choice. They could tick as many as they wanted and there was an other category as well. So embarrassment came up third on the list across the sample. And there was opportunity for open text responses, which we haven't analysed yet. But our impression from our knowledge of adolescents, from our previous work on access back in the early 2000s, where embarrassment also featured in qualitative research, and also from the longitudinal study where we're hearing stories from young people, is that it relates to the self-consciousness of adolescents. It relates to perceived discrimination, judgmentalism on the part of providers. I think that's where that comes from.
Thank you. Over here.
Thank you so much for a really inspiring conversation or presentation. I'm Coco Araswal from UC Berkeley. I was wondering if you could tell us a little bit about the black box between the wonderful data you presented and the fact that it was then incorporated in policy. Because that little magical black box, we often don't have time to share, and the fact that you did that is really important. So I'm wondering how you took the research data and shared it with people in decision-making positions and translated it to actual policy change, because that's awesome. And thank you.
I guess one big bonus is the study was funded by government for the purpose of informing policy. So that was really the purpose of the research. It was funded because there's a gap in the research. So there was already that connection from the outset. But in terms of the process, we had a one-day forum. We presented the findings along with our youth consultants. We had young people from marginalised backgrounds who worked with us to advise us about the study, and they helped sort of really communicate the findings to the audience. And then we had facilitated discussions, which we then synthesised and put into a report. Yeah.
Thank you so much.
Thank you. Was there one more person with a mic?
Yes.
Okay.
And then. Thank you very much for your interesting presentation, and completely agree on the part of healthcare systems reaching out to the young people rather than waiting for young people to reach out to them, especially using technology. I just wondered on that aspect whether your project also looked in depth at the healthcare professionals or professionals' ability, confidence in terms of using technology, because I think sometimes we think professionals or older people can use this technology, and really there is that, there isn't that link. So I was wondering if you looked into that and just the professionals' voice in terms of the use of technology to support young people.
Yeah, there's lots of barriers for professionals to use technology, so having access to the equipment and the skills and the confidence, as well as a lot of bureaucracy and red tape in their own policies and rules from their organisation. But I think there's been quite a big shift, at least in Australia. 5 years ago, some of the research was saying that professionals were very concerned about the risk of using technologies, whereas what we found in the interviews with professionals is that they're saying, look, we're ready to embrace this challenge now, we've got to get on and do it. So we saw a bit of a change happen. I hope that answers the question.
Great. Thank you very much.
Okay, thank you.
So despite my Swiss partner, we have gone slightly over time, so I'm sorry, but I'm sure there's still some lunch left. They've been feeding us quite well. I just want to thank all of the presenters and their co-authors who presented today, and all of the people who funded their work. I think that, as our colleague in one of his questions said, we saw really nuanced presentations. We didn't see any knee-jerk, technology is good, so we'll just do whatever we think is right and it'll work. We heard from many people about talking to young people, about what's going to work for them, about training young people to provide the services themselves, about getting input from the young people, and the young people are on the ground, and not just the easy to find young people, but the more marginalized ones. So I think we have been incredibly honored to be able to hear every one of these presentations today, and I'd like to thank you all very much for attending and for presenting.
Ladies and gentlemen, we have an announcement. Please collect your networking dinner coupon from the registration counter before 4 p.m. Thank you very much.